Now, I'm going to go into business mode, I'm afraid, which is what surgeons are quite good at doing at times, but sometimes it's necessary. My wife says to me, actually, I'm a poor plastic surgeon, and that's because I don't do any cosmetic surgery. I do a lot of skin oncology, and for the last 25 years, I've had an interest in melanoma. Let's see if I'm any more qualified to do this than anybody else. Okay, well, so far, so good. So, I've been involved with the melanoma guidelines and updates, the update that's published in 2022. Oh, no, I failed already. There we go. So very briefly, the talk outline I want to talk about is just how the committee is established. I think that's important for members of the general public to understand. How we've decided on the topics, the recommendations, and then how we come about really sort of summarising all that. It's important to realise that there are specific topics that I'm talking about, and I'm not going to be able to cover all the issues in the guidelines. The meeting went on the meetings went on for 18 months, and I've got less than 25 minutes to try and get through it all. So I'm going to be going at a fair pace. Please catch me afterwards if there's anything that you don't understand. I'm trying to keep medical terminology down to a minimum. The things in purple at the bottom are what has been written within the NICE guidelines. They're purple probably on the TV screens. I have no idea what colour they'll come up on the big screens because there seems to be a big discrepancy. But here we go. So if you look online for the NICE guidelines, what you'll find is that it says a melanoma assessment and management, and it appears to be that it's published on the 29th of July 2015. You actually have to look at the very bottom where it says it was updated on the 27th of July 2022. I don't know why they haven't changed that, but that's how it is. NICE has certain terminology that it uses that I'll be using during the talk. One is considered when the evidence is weak, but they think it's probably a good idea. And offer is when the evidence is much stronger, and it should be considered as a recommendation for an individual. Oh, no, I failed already. So anyway, NICE appoints a chairman. They also employ the backroom staff, the researchers, statisticians, health economists, which are absolutely essential to producing these guidelines. The clinicians come from two areas. There's a guideline committee, which I'll talk about in a minute, and then also invited experts, which are experts that are brought in really to supplement any deficiencies in the committee members' expertise. And then there are people from the general public, and I've met Ian here already today, who's over there. So the committee members it's an open application, so you have to submit your CV, so you're not approached or headhunted. You have to submit to say, I'm interested in doing this. You're interviewed, and provided that's successful and you have no conflicts of interest, such as a major shareholding in a pharmaceutical company that's producing melanoma, or you've got a CT scanner in your back garden, you're probably going to be okay. But NICE are extremely clean, and I would stress this, about trying to ensure that there is no bias whatsoever when they're producing these guidelines. Before every meeting, we had to go through a regular conflict of interest screen. Very briefly, the sort of timeline we had for producing the guidelines covered a review of the current guidelines, identification of areas where either we're missing information or there could be more information that's been produced since the last guideline was produced. Analysis of that information, distilling it down into recommendations. Provisional publication then goes out to stakeholders, and the stakeholders are groups or bodies of people who have written to NICE saying we have an interest in this guideline. It can be charities, so Melanoma Focus was a stakeholder. All the pharmaceutical companies are stakeholders. The professional bodies are all stakeholders. The British Association of Dermatologists, British Association of Plastic Surgeons, etc. And they review these guidelines and they write in comments. The comments are then discussed by the committee members and answered individually. And then finally, once they're refined, the formal publication occurs. The process of the meetings, it's about 6 to 8 weeks. We're having these meetings. They were over Zoom because it's over the pandemic. This was 8 hours a day, possibly 2 days in a run. So they're fairly intense and they're hard work. The pattern that we had is that we would discuss the current regime or the recommendations, possibly with an expert witness who is generally one of the committee members. He would run through the sort of an overview of the whole topic, really to allow the statisticians and the health economists understand what we're trying to achieve. They may note that we may then identify areas that we needed to research further, and that enabled the researchers to focus their literature search to identify if there's any more information that we can add into the recommendations. The following meeting, we would then review the literature search, and we would discuss areas that we want NICE to concentrate specifically on the economic modelling. The meeting after that, we then discuss the economic modelling, and we'd make recommendations following that. In between all that, if there are any gaps in the day, we would then go over the other parts of the recommendation or the current guidelines, which we're not necessarily going to be reviewing specifically, but we would be just checking to make sure they're still up to date. So the topics we selected, we have a scoping exercise. NICE allows you to have about 6 or 7 topics and no more. And that's because of the extent of work that's required to investigate each of these topics. So the 7 topics that we chose were these. So genetic testing, sentinel node biopsy featured quite heavily, as did systemic treatments. And then the real headache was the follow-up regime. And I'll go into more detail on that at the end. But I'm just going to go through each of these topics one by one and try and explain to you why some of the considerations, recommendations were made. So genetic testing, we recognise that there is variation throughout the UK as to the speed at which genetic tests can be done. It can be days, it can be sort of weeks sometimes. And some patients, as Michelle just said, you know, your situation can change extremely rapidly and you don't have necessarily time for weeks for a BRAF test to come through. And so in 2015, it was recognised that we should be offering it for stage 2C to stage 4 patients as a routine. But in 2022, we also thought we should consider patients who are stage 2A and 2B, really just to make sure that we've got that information available. It still wouldn't have helped, you know, Michelle, as she just explained, she wasn't that when it all started, until, you know, she'd had her sort of sentinel node biopsy. The other important thing was that the local MDT, so your local team should be organising this, not arranging or asking the regional centre to do it. That's because there's a lot of tissue that needs to be found, transported, processed, and that all takes time, it costs money, and there's a potential to lose the tissue in that transfer, or mislay it, I should say, rather than lose it. And that can be precious time, and we're trying to avoid that. And finally, the recommended treatment was the IHC, which is immunohistochemistry. That's one of the stains that they can do on the specimen. It's very good, it's very quick, it's relatively cheap, but it's not quite as accurate as the IDILA, which is one manufacturing method, or the next generation sequencing, which is the NGS. And so therefore, if the IHC is negative, then it should be considered that you look at other alternatives. Sentinel node biopsy. Again, I'm just going to run through this. For the low risk melanoma, stage 1A, it decided not to do a sentinel node biopsy. No imaging before sentinel node biopsy unless the metastases are suspected. This is potentially a controversial situation, but it's felt to be in the patient's best interest, not necessarily to identify a small lymph node prior to having a sentinel node biopsy. And I'm happy to talk about that at the end in question time. If you have a melanoma that's 0.8 to 1 millimetre, you could be considered for a sentinel node biopsy, but only if you have ulceration, angiolymphatic invasion, or mitosis, that's cells dividing, of greater than 2 or more per millimetre squared. And that's because your risk, if you have that combination, your risk of having an involved sentinel node is just about at the threshold of 10%. And below 10%, it's felt really that it is economically not beneficial to be offering that to everybody in the UK. We also talked about pregnancy, and that was really around the risks of that were around general anaesthetic, which the risks are low. Radiation, it's very low. You can be a nurse working in theatre and do 300 of these a year, even if you're pregnant, and it's still safe. But there's concern over the patent blue dye. This is an unlicensed drug. In other words, we're not officially allowed to be using it for this, but we've been using it for 30 years. So we're going to carry on using it. The government's got enough on its hands at the moment to start worrying about a bit of blue dye. It happens to be a food colouring, just for your interest. And I thought at the bottom I'd put what we do in Leeds for patients who are pregnant, is that you do a modest re-excision around the scar, you wait till the pregnancy has finished, you then organise a formal wide local excision and sentinel node biopsy. But you ask the mother to express milk and to store it in the fridge for 48 hours. Once you've had your sentinel node biopsy procedure, you then continue expressing milk, but you bin it again just for 48 hours, and you use the milk in the fridge to cover that period. Surgical histological margins, again, very standard. Interestingly, stage 1 and 2 is what NICE now recommends, but all the evidence that is out there on margins does not use stage 1 and 2. It uses Breslow thickness. Stage 1 and 2 also incorporates ulceration, which was never considered in any of the formal surgical margins. We decided in 2022 that we should take into account the margin again to try and limit potentially either the surgical impact of having a significant scar at a site that might have a cosmetic or functional impact. And therefore, if you've had a 5mm margin taken when you had your primary removed, and you just need to have a 1 centimetre margin, what you actually need is an additional 5mm, and then that will give you your centimetre margin clearance. This is, again, just to try and clarify for any of you that have got hold of your pathology reports and you're saying, well, I haven't had my centimetre or 2 centimetre margin. It's important to realise that there is a clinical margin, which is what we're talking about when we talk about margins for melanoma. And that's the 1 centimetre or the 2 centimetre. When you put the specimen into water, it shrinks. And so therefore, when the pathologists report it, they report on the shrunken specimen. And there's about a 20% shrinkage. So an 8mm histological margin is equivalent to a 1 centimetre surgical margin. So I hope that allays any fears that people might have that they haven't had adequate surgery. The next point is that actually this is a situation of where not less is more, but less is the same. Historically, and this dates back to the very late 1800s, that on the basis of 4 or 5 patients, a 5 centimetre margin was recommended for all melanomas. And that stood the test, well, stood not the test of time, but was in place for over 50 years without any evidence, no scientific trials or whatever. Pippa's given us a good talk today about the benefit of trials, and there have been questions about, oh, I'm not too sure if I want to have less drugs. These are trials that we've now shown that 5 centimetres is no good, 4 centimetres makes no difference, 3 centimetres makes no difference, and we're now down to an option of 1 versus 2 centimetres. But actually, in reality, when we're operating on people, if the melanoma is on an awkward site for either functional or cosmetic reasons, and I've put down there head and neck, digits, perineum, a 1 centimetre margin is entirely appropriate and accepted, and there's no evidence to show that it has a detrimental effect to somebody's overall survival. So we've talked, Pippa's also mentioned the Melmark trial, that is ongoing at the moment, and it's looking to see whether a 1 versus 2 centimetre margin, 1 centimetre is equivalent to having a 2 centimetre margin. The preliminary pilot study, again, has showed no issues on this, but this is a much bigger study that we're looking at. Come on. What's happened now? I did nothing. Can we have it back on again?
You've got a completely blacked out slide on your presentation.
Where are we? No, we haven't got black slide. Good. Okay. So anyway, so the next recommendation was for micrometastatic disease. So this is patients who've had a positive sentinel node biopsy and whether they should go on to have a completion lymph node dissection. Now, again, we've got to look at history. History was such that if you presented with a palpable node or node that was detected on imaging, it was recommended you had the rest of the lymph nodes removed. And what we found is that 50% of the time there'd be other lymph nodes involved in the rest of the specimen. Subsequent to the various sentinel node biopsy studies, what we found is it wasn't 50% involvement, it was 20% involvement. So in other words, if you have the rest of your lymph nodes removed after a positive sentinel node, only 20% of people we will find additional nodes involved, which means that 80% of people were going through having a completion lymph node dissection with no benefit whatsoever, having big scars, the risk of bleeding, and most importantly, long-term consequences of lymphedema, which cannot be underestimated. So in order to address that, there were 2 studies which both reported, you'll see, after the last lot of the NICE guidance in 2015. These randomized patients who had a positive sentinel node to either having a completion lymph node dissection or to having observation with ultrasound. They had to do ultrasound because they had to add something in, because the standard of care at the time was to have surgery. And you would never be able to recruit patients to a trial that said you're going to have surgery or nothing at all. Who's going to vote for that? So what they did was they did surgery, and we'll do the least invasive test that we can do that's simple and cheap, an ultrasound. And so that's how the test arose. What they found, not surprisingly, is that if you have all the lymph nodes removed from your lymph node basin, they're not going to recur there, or it's highly unlikely to recur. Okay, so that's logical. Most importantly of all, that they found it made no difference to the survival as to whether you had your lymph nodes removed immediately after your sentinel node biopsy, or if you had them removed, should they subsequently recur in the future. So as a consequence of that, the 2022 recommendations were that you do not have a completion lymph node dissection after a positive sentinel node biopsy. There are a few variations on that, which again we can discuss, but there's a general rule, that's what we're doing. So the use of sentinel node biopsies to patients with stage 3 N1C. That's patients with micrometastatic disease on their primary. So this is, if anyone was here last night for Sir Chris Bryant's talk, this is the disease that he had. And this is where you've got your primary melanoma and you've got some budding seeds off the melanoma that are still seen within the first pathology specimen. So this is the pathologist looking at your main melanoma and saying, not only have you got one melanoma, but you've got lots of little seeds around the outside of it. That's your stage 3 N1C. That's micrometastatic disease. Microsatellite disease. I do apologise. Why is that important? Well, when you have the presence of microsatellites, it upstages you to stage 3B and 3C. That means that the benefit of sentinel node biopsy is lost because one of the points of sentinel node biopsy is it gives you a prognosis. It gives you an idea of what may happen to you in the future. So you lose that. And the debate over the therapeutic benefit of sentinel node biopsy has been raging for some time, but there's certainly no therapeutic value here because the microsatellites upstage it. What it says is that you are at a high-risk group for having further problems from your melanoma, in other words, distant disease. And so the recommendations there was you do not do sentinel node biopsy for patients who've got microsatellite disease. All right, okay, and the reason, just very brief, I don't have a pointer here, but what colour we've got? Okay, so the top line, which is black, is those patients who don't have any microsatellites. The bottom collection of lines are those either have microsatellites, in-transit disease, which basically are macrosatellites. So those are little small cells that have grown into something that you can either see or you can feel, or they have been detected on scans. And the third line is when you've got both in-transit and microsatellites. So what you see is that your 10-year survival drops significantly if you have microsatellite type disease. So we then moved on to patients who'd had more extensive disease. Now, Don Morton, who's a famous American surgical oncologist and was responsible for bringing everybody sentinel node biopsy, said there are only 3 treatments for melanoma. That's surgery, surgery, and more surgery. And when he was working, that was right, because we didn't have any of the fantastic developments we've got in systemic treatment at the moment. And it's still applicable now. So for some patients who have got recurrence of their disease, whether it is distant disease or it is localized, okay, I've got 5 minutes, I'm going to have to get the move on. Localized, there are a variety of options. Surgery is the first one. Systemic treatment is one of the options, but there are also other treatments that are recognized by NICE. TVEC is a herpes virus, electric chemotherapy, isolated limb infusion, imiquimod, etc. These are all things that are licensed to be used in this situation. But we decided that it was important that the patients should be referred through to the regional centre for discussion of this. Information of the centres and what services they have got are on the melanoma website. Systemic treatment, again, we've talked a little bit about this today. First line essentially is immunotherapy if you're able to cope with it and it's suitable. Targeted therapy would be your second option. And as a general rule, there are obviously other medical considerations to be thought about. All right, follow-up. this is a contentious thing, and I haven't got a pointer, but if you look at on the left-hand side, you'll find 2015, and essentially from 1B down to stage 4, the follow-up was exactly the same. It was 3 monthly for 3 years and 6 monthly for 2 years after that. The 2022 version has significantly scaled this down, and the break-off point is around about 2A. So 2B and below, the follow-up is still fairly similar, but 2A and above, it's been significantly reduced. And why is that? And that's because if you look at, and I'm just going to take 1A here, which is what I've circled, you can see that 10-year survival for 1A is actually better than all the other stages at 5 years. And you can go right the way down, and you can get down to stage 2A, which again is not perfect, but the drop-off seems to be between 2A and 2B. And that's why we said that there's no benefit or reason for having really intense follow-up for patients who are unlikely to benefit from it. We should be focusing our efforts on those people that are more likely to benefit. This pointer. Okay, now I can't go on to this is a website. This basically is, if you look on the NICE website, and you can see, it has all the evidence that they go through. This has got 625 pages on just looking at the follow-up evidence for patients. It involves all the papers, all the information. If I had a scroll here, I would go through it with you, and I can't. But that's one of the reasons we only have 6 or 7 topics that we can cover. Recommendations for staging. Basically, we talked about considering an offer. Stage 2B, contrast-enhanced CT scan, whole body and brain. In Leeds, we don't do the neck if the primary is below the umbilicus. MRI brain, because that's more accurate than CT. However, there are logistical issues about trying to organise an MRI scan and a CT scan on the same day. Interestingly, what we did find in the research is that if you have a scalp primary or you have mitoses of 5 or more, you're more likely to have a brain metastasis, and therefore an MRI brain probably should be considered the staging modality of choice. And as I'm sure Pippa and the rest of my medical oncology colleagues will here agree, that after 8 weeks there can be significant change in your picture. So if you're going to be starting adjuvant therapy, you need to have up-to-date scans, and if it's been if it's been more than 8 weeks, they need to be repeated. Stage 4 and the other ones offer whole body MRI if you're young or if you're pregnant. Note that PET scan is not on here. PET scan was acknowledged that it is slightly more sensitive, but when they did a significant cost health economic analysis, it really didn't actually stack up. And so therefore CT scan is the treatment of choice. There are indications for PET, and I'm quite happy to discuss that later on. Mindful of my time. So the other change was the radiological follow-up. I haven't considered the follow-up in 2015 because it was all over the place in the UK. Leeds was a bit of an outlier, and we didn't think that scanning was good. Particularly, one of the reasons was scan anxiety. And there was no evidence at the time to show that it had any benefit. The 2022, the ultrasound has been included because that was involved in the studies, but again, it doesn't necessarily show that it is beneficial for you. The only thing it does do, that if you detect a node on your ultrasound scan, then you may be at risk of having distant disease, and it may trigger an earlier CT scan. I've lost 5 minutes just on this pointer. Right, CT scan, that is then overlaid. So for people who are certainly 2B and below, there's an interaction with CT scans being considered, not offered, being considered again, and that's basically 6 monthly CT scans and 6 monthly ultrasound scans. The important thing is, if you look at stage, we can still see the stage 2A, we're just offering ultrasound scans. If I go on to this next page, the important thing here is that Michelle sort of again is a bit of an outlier here. She pointed to one of her stones that she is a medical outlier. But if you look at the 5 and 10 year survival rates for somebody with stage 3A melanoma, it's equivalent to somebody who's got 2A. And yet for the stage 3A patients, we're suggesting they have CT scans, and for stage 2A, we're not. The reason for that is that trying to say 3A patients are not going to have CT scans was going to get too complicated and too messy, and everybody be screaming and shouting. But actually, there is no evidence to say that stage 3A patients should be having CT scans. It was put in there just to try and make it slightly easier to follow. Final few slides. This is one of the other things we do is we use research recommendations to highlight the areas that are quite clearly missing in the literature. Very final slide. These are guidelines. They are not mandatory. So you can't say to your clinician, you have to do this because they're in NICE, has written them down. These are guidelines. They're guidelines for everybody. They're guidelines for commissioners, they're guidelines for clinicians, and they're guidelines for patients. And it's aimed really to review all the evidence that is there, to look at the cost effectiveness of the services that we can provide. We don't have a limitless budget. Highlights the areas that research should be targeting, and try and establish uniformity of care across the UK. Thank you.